Good morning, friends. It is the continuation of the previous lecture that is on poliomyelitis. In the previous lecture, we learned about how to diagnose the case of polio, how we will suspect that it is a case of poliomyelitis, what is the clinical presentation. Today, we will learn about the most important thing related to polio, that is the immunization, and also the AFP and AFP surveillance. Let's start. So when we talk about immunization, two type of immunization is very important in case of poliomyelitis. That is the oral polio vaccine and the injectable polio vaccine. Oral polio vaccine that has been discovered by the CBME, and this injectable polio vaccine have been given by the SAC. So this oral polio vaccine is a live vaccine. In this live attenuated, that means the virus has been weakened. Whereas in case of injectable, it is a killed virus. So this question many times from this topic it comes as a short note also. It is a very favorite question of the examiners. So oral polio vaccine is available in the trivalent form also, bivalent, monovalent. In trivalent, all the three serotypes have been used. In bivalent, 2 has been removed. Only 1 and 3 is present. In monovalent, depending upon which type of serotype you want to give, you can design according to that. Now, IPV also contain all the three serotypes. Initially, when the vaccination of this IPV has been started, it was given by the intramuscular route, and 0.5 ml is being given intramuscularly. But later on, it has been decided that much better response has been seen when given by the intradermal route, and the dose has also been reduced to 1/5. Suppose we are, because in intramuscular route we are giving by 0.5 ml, so here we need only 0.1 ml. So you will also save the dose, and the response is much better. So 2 doses are needed for this IPV. Then this national immunization schedule. So total 5 doses is being given for the oral polio vaccine. That I will tell you in the next slides. That is, a 0 dose is given at the time of birth. Then first, second, third, when you give vaccination for DPT, that is the diphtheria, pertussis, tetanus, 6th, 10th, and 14th week of the child of the age of the child, and booster is given at the 16 to 24 months. So that is the 5 doses being given for oral polio vaccine. In case of IPV, 2 fractional doses are needed. That is the intradermally 0.1 ml and given at 6th and 14th week of age along with the OPV. If we compare safety wise, so injectable polio vaccine is very much safer as it is a kill vaccine. Oral polio vaccine is safe but not in the immunocompromised person or in pregnancy old age, because at that time the immunity of that person is down, and as it is a attenuated, that means you have only weakened the virus, you have not killed the virus, so it can infect the patient also, and patient can have polio derived, that is the vaccine derived poliomyelitis. Then efficacy wise, if we talk, then the injectable polio vaccine is 80 to 90% efficacy. Oral polio vaccine has much higher efficacy, 90 to 100, even by the 1 or 2 dose. But efficacy decreases by it because there are other enteroviruses also, so they can be interference. Or as we have known that when you are giving the child this oral polio vaccine, the breastfeeding should not be there for 30 minutes before and after the vaccination. So this breastfeeding can also change the efficacy of this OPV and also the diarrheal disease. Efficacy for this is poor as compared to OPV. Then cost wise, IPV is more expensive, OPV is more economical. Duration of protection, IPV has short duration, need boosters when periodically you have to give the boosters. OPV has a long lasting effect. In epidemics, because in epidemic the virus is circulating in the community, and as we have known, we have learned in the previous lecture also, that when there is virus is circulating at that time, if you are giving injection like intramuscular injections, so that can precipitate into a paralytic poliomyelitis. Therefore, it is unsafe when you are giving in the time of epidemic, but OPV can be used safely. Herd immunity. So IPV is not providing any herd immunity, OPV is providing herd immunity, because that virus of this vaccine, live vaccine, when reaches to the gut of the child, it will, by the fecal-oral spread, this vaccine virus will spread. Then local immunity, it is weakly stimulated in IPV, it is strongly stimulated in the OPV. So from the point of view, when you are talking about a community, for the herd immunity, OPV is much better. Then polio vaccine, if we talk about IPV, it can prevent only paralysis, but OPV protect from paralysis as well as from the intestinal reinfection. Storage condition, IPV is relatively stable, does not need anything more extra. OPV should be stored at -20 and stabilized in MgCl2. Then this vaccine associated, chance of vaccine associated paralytic poliomyelitis or vaccine derived poliovirus. So there is zero chance in case of IPV, and it is having more chance with the oral. So there is no chance in case of IPV of this vaccine associated paralytic poliomyelitis, but in case OPV there could be chance. This is the national immunization schedule. So at birth it is the OPV 0 dose, then 6 first dose, 10 week second dose, 14 week third dose, and 16 to 24 months then you have the booster dose. Now what is this vaccine associated paralytic poliomyelitis? So it denotes all the cases of paralytic poliomyelitis that occurs due to the OPV administration. So this has been seen, all the cases where the genetic, if we talk about the genetic sequence of that virus which have been isolated in these cases, so it shows from the main OPV strain, when the genetic difference is less than 1%, we say that these are the cases of vaccine associated paralytic poliomyelitis. And it occurs among the OPV recipients, all those who are taking this oral polio vaccine, as well as there is also risk to the close contacts due to the fecal-oral spread. Now this virus, which is from the vaccine associated, so it is not capable of circulating in the community, it do not cause outbreaks, and what is the chance? That is the 1 per 2.7 million doses. So when 2.7 million doses of OPV has been given, so there is one chance of having this polio due to the vaccine. Then most common serotype which is associated with this type of poliomyelitis, that is the type 3 followed by type 2. Now what is the end game strategy that has been planned from 2019 to 2023? That is the global eradication of the polio virus. So poliomyelitis is now at the verge of eradication, and certain steps has been taken, and lots of this immunization coverage has been done by all the countries worldwide, and there is been support from the WHO to all the countries so that this virus can be globally eradicated. Now this pulse polio immunization was initiated to eradicate poliomyelitis. In India it was in operation since 95 to 96. So PPI can be asked as a short note, what is pulse polio immunization? So there are two rounds of pulse polio immunization. What is pulse polio immunization? That means irrespective of the child has taken any of the normal immunization schedule, that is the national immunization schedule, all the children of 5 years or less than 5 years, they all being vaccinated with the oral polio vaccine. It doesn't matter whether they have taken 3 doses, 5 doses of nation immunization schedule. That is a different matter. They have to take that also. But this, when there are pulse polio immunization, so all the children of 5 or less than 5 of whole of the country being vaccinated with the oral polio vaccine on a single day. So this is usually done during the winter season, mainly in the December, and the next dose is being given after 6 weeks, that is in the month of January. Now these PPI doses, they are the extra doses, but they do not replace the OPV doses. So whatever the nation immunization schedule is there, they have to follow that also, and they cannot replace each other. So both has to be done. And the important another factor for this end game is the AFP surveillance, that is to detect all the cases of the acute flaccid paralysis. In case of acute flaccid paralysis, other diseases are also there, so we have to identify which are the cases of poliomyelitis, and then we can control it. Now this strategy, there were a few goals were there. One goal is the eradication. That is how we can eradicate, that is the interrupting the transmission of all the wild poliovirus. So we have to detect it, and we have to break the chain so that it cannot spread to other children. Stop all the circulating vaccine derived poliomyelitis. So any case of poliomyelitis which has been originated with the vaccine, so that we have to stop that outbreak within the 120 day of detection. Then second goal is the integration, that is we have to strengthen the immunization. So this all the immunization program, whether it is pulse polio immunization, nation immunization schedule, so all that schemes we have to strengthen, and the health system. Then ensure the sensitive poliovirus surveillance, that is this is a very important factor, that we should have a good surveillance system which can detect which area, in which area this virus is being detected, whether it is wild strain, whether it is the vaccine strain. Wild strain means the original strain of poliovirus which is causing this poliomyelitis, and vaccine one is the strain, that virus which has been from the OPV vaccine. And we should be prepared for and respond to the if there is any future outbreak or the emergency. Then goal third is the certification and containment. That is, when you are doing this AFP surveillance, you will know whether there is any case of wild strain of polio in your country, and if it is not there for 3 years, then that country can be certified that the wild polio virus has been eradicated. Like in India, we have got the certificate in 2014. The last case we have found in 2011, and contain all the polioviruses including from the labs. So not only the wild strain, but we have to also contain or stop any of the strain which has been derived from the vaccine also. Now the acute flaccid paralysis and AFP surveillance. So what is acute flaccid paralysis? That means there is a sudden onset of weakness in any part of the body in child less than 15 years. So if any case of paralysis, that means weakness in any part of the body in a child when the age group is less than 15 years, so comes to the emergency with this complaint, they all will come in the acute flaccid paralysis. And what are the differential diagnosis in this case? So one is the Guillain-barre syndrome, second is poliomyelitis, transverse myelitis, post-diphtheritic neuropathy. So when we talk about poliomyelitis, it has been said that any case of the AFP has been reported, that has to be reported to the health center, that means the medical office, chief medical officer of that area. So these cases it is a notifiable disease, so you have to report that, and then that case will be monitored whether it is due to poliomyelitis or is there any some other reason. So for that AFP surveillance, that means the stool sample is being taken to check whether this is due to the poliovirus or something else. Now, the important differential diagnosis when we talk about AFP, that is the Guillain-Barre syndrome. So what happens in the Guillain-Barre syndrome? That is, there is a immune attack, that is the IgM or IgG or complement activation is there, and there is occurring the axonal injury. Then it is also synonymous with the acute inflammatory demyelinating polyneuropathy. Now, how we can differentiate, that is very important. What I want to clear here, that is when we talk about poliomyelitis or Guillain-Barre, both the case, if there is a child is there, so he will present with the acute paralysis attack is there. So how we will know which one is polio or which one is the Guillain-Barre syndrome? So when we talk about Guillain-Barre syndrome, the age is usually more than 3 years. When we talk about polio, it is usually less than 3 years, because usually we notice that in the younger age group, very young age group of the child, they have the polio. Guillain-Barre is usually more than 3 years. Male having the more chances as compared to females, and there is some previous history of infection, some viral infection like cytomegalovirus, Epstein-Barr virus, HIV, Campylobacter, or there is a history of diarrhea. So some viral infection, post-viral there could be this Guillain-Barre syndrome. Now, in poliomyelitis, we have a descending type of paralysis. That means there is paralysis will be more in the your hip, thigh, and as we go down, there will be decrease in the paralysis. Whereas in case of Guillain-Barre, it is ascending. That means the paralysis will be more in the lower part of the limb as compared to upper. So this is very important difference, how the clinician will know whether it is going in the favor of poliomyelitis or the Guillain-Barre. Then second important difference is the sensory symptoms. In case of polio, there is no sensory loss is there, only motor is there. Here in Guillain-Barre syndrome, there will be either hypo, that means the sensation has been gone down, or hyperesthesia, that means it has been increased. Then the third difference is ataxia. That means in Guillain-Barre syndrome, there will be that means that when the patient is moving, his some disbalance, or you say some imbalance is there while the person is walking. So there is ataxia, which is not there in the poliomyelitis. Then autonomic symptoms are there in case of 30%. There could be involvement of autonomic symptoms. So clinically, the patient will be present with pain in back, thigh, legs, along with the motor weakness starting in leg, and it is sending upward. Maximum weakness within 2 weeks, and reflexia, that is the hyporeflexia, that means the reflexes are poor or absent. Tone is also either lost or there is a poor tone, and bladder and bowel function are normal. When we go for the diagnosis, CSF tapping is needed in case of Guillain-Barre. So it will show the albuminocytological dissociation. Electrophysiology, when you see demyelination of peripheral nerves and slowing of the nerve conduction velocity. MRI will be normal. So you will have the finding in the CSF also. Electrophysiology will also show which will be absent in case of poliomyelitis. So when we talk about the treatment of the Guillain-Barre, so intravenous immunoglobulins is being given, what is most important in Guillain-Barre, that is as early as the diagnosis is made, you can correct that situation, because immunoglobulins, if it is being given at time, so it can correct the situation. Plasmapheresis is also equally effective, or you can have the alternative as the steroids. Now comes the AFP surveillance, that is the acute flaccid paralysis surveillance. So this is very important when we are targeting the global eradication of the poliomyelitis. So all the cases of acute flaccid paralysis, they has to be reported to the surveillance medical officer, and so that at proper time a proper sample can be collected to know whether there is any viral strain or the vaccine strain of the poliovirus being circulating in that area. So detailed medical history and investigation has to be needed. Proper collection and transportation of a stool sample, so that when we collect the stool sample and when it is being transported, so that is known as the reverse cold chain. As when we do for the vaccine, it is being said as cold chain, but when we do for the stool sample, it is a reverse. So a proper temperature is being maintained while transporting the stool sample. Now, then the search for the any additional cases being affected. If it is a case of poliomyelitis, so you have to also know that any other person has been also been taken the infection or any outbreak has been occurred in that community. So 60 days follow-up is being done for those cases who have been come with the acute flaccid paralysis, and all the lab results will be analyzed and then it will be reported. So stool specimen collection for every case, how many stool specimen are needed? That is two stool specimen are being collected at least 24 hours apart and ideally within 14 days of onset of fire. So that is the rule for the surveillance, that any suspected case of acute flaccid paralysis is suspecting of poliomyelitis, two stool specimen 24 hours apart, that has to be taken within 14 days of the onset of paralysis. And if late reporting is there, then it can be collected up to 60 days. So voided stools sample is preferred. Each specimen should be 8 gram, collected in a clean dry screw cap container, and it is being transported in the cold chain, that is the reverse cold chain. Cold chain is being used for the immunization. Poliovirus, then being, if it is being isolated, then we should know whether it is viral strain or it is, that is by the, how we will know, that is about the how much genetic sequence is matching with the old parental strain. Then a case is classified as polio if wild polio is isolated from the stool specimen. So that is all for this poliomyelitis. This AFP surveillance, immunization. Immunization is the most favorite topic from this poliomyelitis that can be asked in the Viva question or in the MCQs, NEET entrance. So all there it is important. If you have any doubt, you can ask me in the comment section. Thank you.